Hello and welcome to the Mindful Learner. Today we're going to talk about anal cancer. The incidence of anal cancer is not that common. It constitutes about 3% of all GI cancer. 80% of those are squamous cell carcinoma. They can spread most commonly via local invasion, like moving upwards, appear like arising from the rectum. Circumferentially can involve the sphincter, causing incontinence, or the vaginal septum, causing fistula. Lymphatic route, 1/3 of the patients will have inguinal lymphadenopathy in their clinical findings, and in advanced cases, hematogenous spread. Anal cancer presents in various ways. The diagnostic workup include a clinical history and examination. Patient typically presents with pain and bleeding. In fact, it's a very painful condition sometimes. 25% of the cases present with anal mass. There is also the pruritus, discharge, history of anal incontinence, or features of rectovaginal fistula. On clinical examination, the most important examination is DRE. You can sometimes see an ulcer which has the appearance of a malignant ulcer, which is raised, everted, and indurated. DRE often is very painful, which is why we cannot often do that in clinic, and we need to do it under anesthesia. And you can also feel a distorted anal canal. As mentioned, palpable lymph nodes are present in 1/3 of the cases, but only 50% of them will actually harbor metastases, and the rest of them will be actually reactive lymph nodes. The most important examination or investigation in anal cancer is EUA and biopsy. As mentioned, it is a very painful condition. Therefore, to adequately assess and to take biopsy, you need to put the patient under anesthesia. Notes should be taken of the lesion size, perirectal lymph node, vaginal involvement, whether it's a mucosal tumor or an exophytic tumor. MRI pelvis should also be done, and that is important for radiotherapy planning. It should also measure the craniocaudal length of the tumor, relationship of the lower border of tumor to anal margin, extent of the quadrant involvement, depth of invasion, and infiltration to the surrounding organ. Staging CT scan is also needed. And gynecological examination, screening for cervical or valvular intraepithelial neoplasia should also be undertaken. These are essential investigation for an anal cancer. Additional testing that is recommended, HIV testing, especially in cases of patients who are known to have multiple partners. The ulcers are multiple and sometimes if they are recurrent. PET-CT scan, especially important for lymph nodes. HPV-16 virus check. Extra investigations that are center specific are EUS of the anal canal and FNSC of the lymph node of the inguinal region to differentiate between reactive or metastatic lymph node. All patients should be put to the anal cancer MDT before making any treatment plan. Squamous AIN is a precursor dysplastic lesion, which are divided as low grade or high grade. Usually the low grade lesions are typed under AIN1 and the high grade lesions are typed under AIN2 or 3. Anal cancer can be divided in as per as TNM classification, where the TX you cannot assess, T0 there is no evidence, TIS precancerous cells in the mucosa, which is equivalent to high grade ACC, T1 less than 2 cm, T2 2 to 5 cm, T3 more than 5 cm, and T4 means irrespective of the tumor size, if it's invading to the surrounding organs, it's a T4 tumor. Lymph nodes similar. N1A is inguinal or mesorectal lymph node or internal ileal group. N1B is involvement of the external ileal group, and N1C involve the lymph nodes of both groups. And if any metastasis is present, it is M1. The role of surgery in anal canal is actually quite limited and in special situations. If the anal cancer is an anal margin tumor and it's a stage 1, then local excision can be undertaken. However, if the resection margin is less than 1 millimeter, then the patient receives chemoradiotherapy. And chemoradiotherapy is actually gold standard for anal cancer, especially of stage 1 and stage 2 and stage 3. Definitive chemoradiotherapy involves 5-fluorouracil, mitomycin, and radiotherapy on the area. Residual disease, if present, then can be managed by surgery. If it is stage 4 disease with metastases, then depending on the patient's fitness, it can be either treated with chemoradiotherapy, and if the patient is not fit, then it's best supportive care. Surgery has roles in special circumstances. Many of the tumors present with either fistula or incontinence, and in that case, surgery is required to form a colostomy to defunction the area. However, most of these colostomies end up being permanent, so it is important to give this patient an end colostomy, not a loop colostomy, and rather than an ileostomy, a colostomy is preferred. It can be either open or lap assisted, and also to counsel the patients adequately. The chemoradiotherapy can be started after 2 weeks of the surgery if there is no complication. The additional role of the surgery is in residual disease. If there is residual disease present, then salvage APER or pelvic exenteration can be done. If there is incomplete chemoradiotherapy due to the toxicity of the chemo or any other conditions such as transplant patients couldn't complete the chemoradiotherapy, had radionecrosis, then radical anorectal excision can be done with flap reconstruction. Incontinence and fistula can also have APER, which is abdominoperineal resection with flap reconstruction. Recurrence of the tumor, if the patient had previous full radiotherapy and the tumor has still positive, tumor still comes back, then we go for an operation sometimes. Curative radiotherapy cannot be given if the patient has received pelvic radiotherapy for whatever reason before and has a lot of bowel or has developed complication from beforehand. Then sometimes we cannot do that, and in that case we do surgery. If it's an adenocarcinoma variety, then surgery is the choice of treatment. And of course, in very rare cases, if the patient doesn't want to have the chemoradiotherapy but rather opt for surgery, this rarely happens. The follow-up of anal cancer is based mostly on clinical examination, which is DRE and clinical examination of the abdomen to detect any lymphadenopathy. It is mostly timed in 3 to 6 months for 2 years, then 6 to 12 months for 5 years. If there is no residual or relapse at 3rd and 6th month, then annual CT in 12, 24, and 36 months. In locally advanced cancer, MRI is suggested in 12 months. However, in some centers, they do MRI in 6 monthly or 12 monthly, depending on the grade of the tumor. This is a very short summary of anal cancer, just to refresh and to serve as a study buddy. Thank you for your patient listening, and I would love to have any constructive feedback to improve my presentation and my channel, and I will be very happy if you subscribe. Thank you.